Just going to invite Cristian Gonzalez Prieto onto the stage to talk about machine learning and dementia risk using routinely collected data. Cristian is a statistician. He's got a master's in statistics from the National University of Colombia, and he's actually currently doing a PhD with the computer science department at the University of Auckland, supervised by Claudia and Sarah and Callum, which many of you will know as well. So over to you.
Thank you, Amy. Yerakoto. My name is Cristian Gonzalez, and I'm doing a PhD in computing science, and I'm going to present kind of the preliminary results of my last year in my PhD. So, well, I remember last year I came here to present what was the project I had. So now I'm going to show what is the results that I got, which is quite exciting. And I was telling last year that, well, the most important thing to work in dementia is because the numbers is actually no great and seems to be worsened as the years go ahead. So try to use AI to help us to identify dementia in time would be really helpful. And in New Zealand, the epidemiological information of dementia is it's very limited. So this study helped to build on knowledge in dementia. However, there have been some studies using national data, and that studies have been able to kind of estimate the prevalence of dementia, and it's found that it's around 9.2% using information or using capture methods. And there are some of the studies worldwide that estimate that 60% of the cases in dementia remain undiagnosed. So the motivation of this, as I said before, is why it's important to use AI to try to help to identify dementia in time. So basically, there are things that you know more than me. That is basically the impact on the patient and also the impact of the caregivers, also the stigma that the disease has in the society, and also for the burden in the healthcare systems. And one idea is that if we are able to identify dementia, this can help us to optimize the brain health, even if the patient has a diagnosis of dementia. So what is the goal of this study is basically develop an accurate machine learning model or models that use routinely collecting data to identify dementia. The other part about ethical attitudes is basically all part of the PhD, but I'm just going to address here what was the models that we train and test. So the data, we use all the data from all patients that has had contact in Middlemore Hospital. And we used several databases, including hospitalization usage, demographic data, age residential care data, which has been more mentioned here, which is interesting, lab tests and interRAI data as well. That's why I'm here. So the first problem that we face is not all people has a diagnosis of dementia. And we want to train models to learn how the different patterns between dementia and no dementia, we need to have a label of dementia. So how we ascertain dementia, we use 3 databases, interRAI data, pharmacy data, and hospitalization data. And if in those 3, in at least on one of those 3 databases, people has something related with dementia, like an assessment on a code or anti-dementia drug prescribed, we are going to say that that person that has dementia or is living with dementia. And then we do a nested case control design. So we match controls with cases by age and how the amount of information that they have available. We didn't want to match by gender or ethnicity because we wanted to see what is the impact of that features in the actual prediction. So that's why we didn't include that features. So the final sample is around 137,000, and of them, 8,195 were labeled as living with dementia. So the machine learning pipeline is basically, as I say, is a nested case control design. So then we prepared the data. So that our idea was try to use the data before the diagnosis to see how powerful was the models to identify dementia in time. So we create 6 different time windows before the diagnosis of dementia. So it's like 0 days, 6 months, 1 year, 3 years, 5 years, and 8 years before the diagnosis of dementia. And then we train and test those models in those data to see how powerful or how well they work. So we use 7 different machine learning or deep learning models, able to manage also the sequences of the data and also the cross-sectional data. And we also play with the features. So we include all the features, all the variables in the data sets. We also excluded all the longitudinal information that didn't have enough information. I mean, there are people that only have 1 test and that's the only information. So we tried to discard that information. We also did like a feature selection where we discard from the data set those variables that didn't have a significant difference between dementia and no dementia. And at the end, we also try to exclude the age residential care related features to see what is the impact of that features. And here are some of the results. So basically what we can say here is first, age residential care is one of the most important features to identify dementia before the diagnosis. Also, we also identify that when we have all the information, and this aligns with some studies in the past, is like the results of the performance of the models is actually better when you include all the features. So data-driven is get more better results than when you do like a feature selection or knowledge selection in the features of the data set. So this is not very good, but anyway, this is just one of the particular models that we train. So basically, this is kind of some of the measures of the performance. And this model in particular, we're able to identify dementia around 80% with 80% of accuracy, which is quite good and is aligned with all the international works that try to do the same. But the most particular or the most important thing here is like our models were really high specificity, which is a good thing that we wanted because we want to avoid the ethical of no harm. I mean, we want to get that. So what we cannot see here is basically in the 8 year, we're still able to identify dementia with 67% of accuracy, which is quite good to try to identify 8 years before of the diagnosis, which is quite interesting. This is, well, there's a lot of information there, but the most important thing here is like the variables that are more important. Well, you know that deep learning models are known to be a black box. So you put information and you get the results and that's it. So what we will try to do here is try to see how important are the actual feature to the prediction of dementia. And we found that one of the most important is actually all the features that are related with age residential care. This is quite interesting because, I mean, we try to think, why is that? Why people that has before a referral to the diagnosis or no referral, but why is that so important for the prediction of dementia? We also found as well that outpatients assistant attendance, the health older person, that's also is important for the prediction, and also the ICD-10 codes. Of course, the comorbidities are very important for the prediction of dementia. Ethnicity is also one of the most important features that we found. And well, there are another things that align with the literature, like antidepressants, antipsychotics, all are really appearing here as important. So how are these were related, or in terms with the international studies that try to do the same? Well, this work is actually quite high. The specificity is really high compared with the others. The AUC, which is kind of like a balance between sensitivity and specificity, in this case, rank in the classification rank at third. And the difference with these two is because these two has a higher sample size and a higher number of variables included into the model. So that may explain why they got better performance. And in the prediction in time, again, our model has the best specificity among those ones that reported that metric. And this is kind of obvious, but of course, when you're getting farther from the diagnosis, for the performance metrics are decreasing because it's difficult for the model to try to find the different patterns between the two classes. So what are the challenges from here and now and the future? But basically, working with routinely collecting data is quite good because there is like a rich information there, but the data is really messy. So it's quite difficult to handle this information and try to make it more useful for as an input for the models. But still, we found that it's really good for research. We found also that one kind of limitation, the way that we find the dementia label could actually underestimate the numbers, and that could also affect the performance of the models. And also the analysis of the features to see how important they are is really expensive computationally. So it takes almost 1 week to get that information. So what is the future work? Basically, we want to an external validation. So we would like to test these models in another New Zealand facilities, health facilities, like another hospitals, extract the data and test the data and see how well models work. We like to use or integrate these models into a software that could help as a case finding system to undiagnosed dementia and try to reduce those numbers. And at the end, we like to use another approach to use survival analysis with machine learning to actually know what is the risk of get dementia in the future. And that's it. Thank you very much.
Thank you, Cristian. Any questions from in the room?
So we use three.
Sorry, I'll repeat that. So how are you saying that people do have dementia? So based on,
So basically,
okay, I've got it, I think. So if it turns up on their interRAI as a diagnosis or on their hospital discharge summary or they're on a medication?
exactly. So if one
Okay.
person has, for example, a
Right.
prescription for any anti-dementia
Okay.
drug, we are going to assume that's
Right.
because
So
they have dementia.
someone else caring for them has recognized they've got dementia and put the diagnosis in their health record?
Yes.
Yeah. And so the strongest correlate or the strongest predictor was the person was already in residential care? Have I got that right? So
Well, we don't know if they're high correlated, probably, because what we have is, we have the labels, and then we use age residential care if they have been referral or not. And then that appears that it's important. Probably that's because, yes, as you say, that's highly correlated.
yeah.
Another assumption that we are thinking is that because probably that people that goes to the age residential care could be fragile, and there are a lot of different things that when they change the environment could affect, and that could decline faster.
Yeah.
So that's another assumption, but we still, that's hypothesis. We don't know actually what's happening.
Yeah. It'd be great to have general practice information, wouldn't it?
That would be lovely. Yeah.
Which I guess you don't get from Health One there, do you? No. Okay. Thanks.